Hello, and thank you for joining today's virtual educational program with Cancer Support Community Los Angeles. I'm Larissa Montalvo, and I welcome you to this week's webinar titled Sex After Prostate Cancer. Today, we are joined by Dr. Philip Pearson from City of Hope for an overview of anatomy of sex. The effects of prostate cancer surgery, radiation therapy, and hormone therapy will be discussed, including a review of treatment options for erectile dysfunction. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you'd like to learn more about our services or watch past webinars, please visit our website at www.cancersupportla.org. Without further ado, I would like to welcome today's speaker. Dr. Philip Pearson is a board-certified urologist who has practiced medicine in Pasadena, California since 2007. Prior to practicing in Pasadena, Dr. Pearson was in private practice in urology in Seattle. He earned his medical doctorate from George Washington University School of Medicine in Washington, D.C. He is a frequent presenter, researcher, and lecturer, and has authored and co-authored several articles in urological literature. Welcome, Dr. Pearson.
Thank you. Thank you very much. And thank you for having me today and allowing me to speak. Be nice to do all of these in person, but here we are on the webinar, and I think that works great too. Well, today we're going to be talking about sex after prostate cancer. This is obviously a little bit of a delicate subject for some people. We're going to try to keep it light and not get tied down too much with taboos. I want to again thank the Cancer Support Community of Los Angeles for allowing me to talk today. And let's get right to it. So today what we're going to be talking about are these topics. And if we're going to be talking about sexual function in men after prostate cancer, first of all, we need to know a little bit about sexual function in men normally, and that's going to be this discussion of the anatomy of sex in men and how that functions. Then we're going to be talking about prostate cancer and the treatments for prostate cancer and how those treatments affect sexual function in men, including surgery, radiation therapy, hormone therapy, because these all can have differing effects on sexual function. And then at the end, we're going to talk a little bit about if patients do have problems with sexual function after treatment for prostate cancer, what do we do about that, and how do we help those people? First of all, we're going to be talking about normal anatomy, get just some basic framework so we're all on the same page about how things work normally, so that if we do have surgery or radiation or something like that, we can know a little bit more about how those might affect sexual function. We're going to be talking about the role of the prostate. Veins, arteries, and nerves are essential for erectile function and sexual function. Hormones are important. And then what I like to call, it's all in your head. A little tongue-in-cheek, but stress, depression, anxiety, these things all affect sexual function in a myriad of different ways. Let's start with the prostate. This is just a little bit of anatomy where the prostate is. This is the prostate here. I hope you all can see I've got a little highlighter there in green. This is the prostate here. Bladder is here. Urethra, where the urine flows right through the center of the prostate and out. Rectum, anus is here. So this is where the prostate sits, deep in the pelvis. And I get a lot of questions. What does the prostate do anyway? What's the role of the prostate? And what the prostate does is it makes the seminal fluid for ejaculation. That's all it does. And so the sperm come from the testicles here, go into the prostate, and then are bathed in the seminal fluid for ejaculation. Now, it seems very simple, but that fluid has the right pH, viscosity, glucose, fructose, so the sperm can survive as long as possible, find the egg, procreate the species, and so forth. So it's a very important function. But once you're done having children, the prostate really doesn't have much of a function after that. The one thing that we do find is as you age, the prostate does tend to enlarge, just benign enlargement, and that can interfere with urination because the urine flow comes right through the center of the prostate and out. And so if you have enlargement here, it can crimp on the urine stream and interfere with urination just as a byproduct. Now, this is a very simplistic drawing of the prostate. If we're going to talk about doing surgery or something like this for prostate, and you go to medical school, what you'll need to know is a little bit more involved. So this is actually what's around the prostate. And here's the prostate here. I'll see if I can draw that out. Way deep in the pelvis, in amongst all of these structures. And so it's a really very complex picture. But for today's purposes, let's just stick with that. Okay. So let's move on. What I'm going to talk about next is the path of sperm, okay? So again, a very low volume of fluid is with the sperm that comes from the testicle, and it comes through the vas deferens here around, gets bathed in the seminal fluid from the prostate, and comes out there, okay? These are the vas deferens tubes. So if you do have a vasectomy, this is where that takes place. I'll show this to you in another diagram here in 3 dimensions. You can see the 2 vas deferens coming up here, and around to the prostate here, okay? Now, that's the path of the sperm and the vas deferens. What's important in sexual function is erection. And in order to have erection, we're going to be talking about the, let's see, nerves, arteries, and veins. Let's see, I want to advance. There, oh, too many. There we go. So this is called the neurovascular bundle. We've got, again, nerves, arteries, and veins. And what happens is the signal comes down through this nerve plexus. And here we're looking at this basic anatomy, this top picture here. Down here, here's the prostate. And you can see that the nerves run right alongside the prostate and then into the penis here to give erection. These nerves are essential. Down here, you'll see again, just from an anterior or top-down view, the nerves, the bladder and the prostate. And here, this is after surgery. So here you notice the prostate's been removed, but those nerves are still here to preserve erectile function. Okay, that's called this nerve-sparing procedure, nerve-sparing technique, and is essential for maintaining potency after prostate surgery. Now, on a more minute level, we're looking at erection from a biochemical standpoint. And let's start over here. We have sexual stimulation coming down the nerve. Okay, so this is the nerves that we were talking about in the previous slide, the cavernous nerves. They submit nitric oxide, which is a neurotransmitter. All of this sort of complex stuff happens, and we end up with smooth muscle relaxation that leads to erection. And what that is the smooth muscle within the arteries in the penis, so that if those smooth muscles relax, the arteries open up, you get blood flowing into the penis, and then that's what makes the erection. Okay, so all of these things have to be intact in order to get to this part. And I'll point out one other thing while we're here. This is, we'll talk about later, PDE5 inhibitors act here. PDE5 is a class of medications. The classic example of one is, of course, Viagra. This is where Viagra works for erection. What happens in the blood vessels when that occurs is you go from here, where things are contracted, over to here, where they're relaxed. You get blood flow into the penis and you get erection. Okay, so this sort of gives us a picture of the important things for sexual function in men: the nerves, the arteries, and the veins. Next, we're going to be talking about hormones. These also are essential. You need to have testosterone. This is the male hormone, also called an androgen. You won't be quizzed on this biochemical reaction here, but this is what testosterone looks like. And here's what testosterone does. Now, testosterone is produced here by the testicles, okay? It starts, though, as a stimulus from the brain, the pituitary gland, through luteinizing hormone, goes to the testicle produces testosterone. This goes into the bloodstream and goes throughout the body to have all kinds of effects. And these are the effects that you might see from testosterone. All kinds of things. What we're going to be concerned with today is this, with libido and mood, and here with prostate growth. Okay, so another thing that we're going to be talking about later in terms of one of the treatments for prostate cancer is called hormone treatment. And that's because testosterone feeds the prostate, but it also feeds prostate cancer. And so if a patient has prostate cancer, sometimes we'll give medications that block testosterone and therefore block that cancer growth. And so that's the role of those medications like Lupron, and this is where that has an effect. It also affects, of course, here. Okay, so we've got nerves, arteries, and veins. We've got hormones. What else is important in sexual function? Well, all of this. And so things like stress, anxiety, depression, diabetes, these kinds of things can all lead to problems with sexual function. And you can have arteries, nerves, blood vessels all working perfectly well, normal hormone level, but if you're anxious and you're stressed, it's not going to work. We don't know exactly how that works, but certainly we found that to be true. And so sexual function is a matter of arteries, blood vessels, and hormones, but it's so much more than that. Excuse me. Now, in terms of how this all works normally, we've discussed that. What if you have prostate cancer? Will all these systems still work? Can you still have sexual function after prostate cancer? And I think the answer is clearly that you can. Okay. Just a diagnosis of prostate cancer is not going to inhibit any of these functions. Certainly, you can have normal sexual function after a diagnosis of prostate cancer. Won't be any effect on it whatsoever. But what can have an effect, and what does have an effect, is when you have treatment for prostate cancer. And those treatments, again, because of the location of the prostate near those nerves, arteries, veins, and some of the treatments affect hormone levels, you can have an effect on sexual function secondary to the treatment of prostate cancer. we're going to talk a little bit more about that now. Here's a slide about the options of management for prostate cancer, and there are lots of options. Prostate cancer has gone through a lot of changes over the years in terms of how we are addressing it and how we're managing it. What a lot of people are having now is what we call active surveillance. Okay, so this is where we're not doing any definitive therapy, we're just following it. The reason for this is that we have found that over the years, we have tended to overtreat prostate cancer, that we have patients that have either very low risk disease or low risk disease, or what we call a favorable intermediate category, that oftentimes the prostate cancer, even if left alone, will not cause a lot of morbidity or mortality. In other words, it's much more likely that somebody with a very low prostate cancer, it's much more likely that they would pass away someday, some year down the road from heart disease, stroke, hypertension, getting hit by a car, who knows? But the chances that they die from their very low risk prostate cancer are very low because it's so slow growing. And so we found that more and more we can undergo active surveillance. Obviously, in terms of today's talk, if you're undergoing this, there aren't really side effects except for the possibility of stress just from knowing what's going on. But otherwise, you can certainly maintain potency through. In terms of active surveillance, this is monitoring the PSA. This is the prostate-specific antigen. That's our blood test. That's our screening test for prostate cancer. And we check that every 3 to 6 months. Oftentimes, if you're diagnosed with prostate cancer by prostate biopsy, we'll need to do a confirmatory biopsy to make sure that we know what we're dealing with, that this indeed is a low-risk prostate cancer. Keep in mind that not all prostate cancers are low risk. In other words, somebody who's diagnosed with prostate cancer in their 50s or 60s and they're found to have an aggressive high-risk prostate cancer, that's a whole nother thing. And we really need to be aggressive with treatment there because those can progress and they can cause morbidity and even mortality. But if it's a low-risk prostate cancer, oftentimes what we'll do is repeat the biopsy to make sure that we're not missing something. And if we know that we have a low risk or very low risk prostate cancer, we'll just follow them with periodic repeat biopsies or MRIs and the PSA testing. This is a little bit off topic, but the MRI has become more and more useful in terms of diagnosing prostate cancer. It doesn't give us a yes or no answer in terms of whether there's cancer there or not, but certainly can help us follow it. And it can help in terms of guiding our prostate biopsy to the right high-risk areas. Now, if you do have a prostate cancer that needs treatment, the options, there are a lot of options. One, of course, is surgery. There's radiation therapy. And then, as I said, hormone treatments. Okay. The surgery we're doing now is a robotic prostatectomy with nerve sparing. Okay. So this is much less invasive than an open surgery. It's done with an operating robot. And I'll show you the Da Vinci robot here. If you'll see here, this is the surgeon. This is me sitting here. Well, it's not me exactly, but this is the surgeon. And you can see here, he's got control here with hand instruments right and left. And then down by his feet, there are 7 different buttons that you control with your feet. And then what the surgeon does here at what we call the console controls these robot arms at the patient bedside. And so what this nurse is doing here is loading this robotic instrument onto the arm. So at the end of this instrument will be a little grasper or a little scissor, and that will help you do the dissection laparoscopically down at the prostate, being controlled all the time here by the surgeon. I've got another picture here. Again, surgeon here at the console. You can see here his hands on the instruments. As he moves these move here in real time. He's looking through this, which gives you a three-dimensional view from the camera, which is right here, into the abdomen. So you really can get the camera right up close to where you're working and have very, very fine control with these robotic arms controlled here by the console. This is a graphic representation. Here, these are these robot arms. You can see the little graspers and the little scissor here. And what you do, again, remember our picture from earlier. This is the bladder, prostate here, urethra and urine channel come right through here. And here we are removing the prostate. And then here we are, the bladder gets reattached to what we call the urethral stump here to reconstitute the urinary channel and allow you to urinate, but the prostate obviously is removed. Keep in mind from our picture that those nerves are going back to the nerves for our erections, run right along here. So you have to be real careful when you're doing this dissection. And remember the other picture with all the other tissue surrounding this that you have to be mindful of in order to do this operation, maintain those nerves, arteries, and veins. And by doing that, if you're doing a nerve-sparing procedure, you can maintain the patient's potency afterwards. Even if you do a nerve-sparing procedure, there still can be trauma, if you will, or stretch sometimes to these nerves that can interfere with sexual function after surgery. And so while if you do a nerve-sparing procedure, more times than not, patients can regain their potency. Sometimes even so, it's a difficult uphill climb to get people back in action after even the best of nerve-sparing procedures. Okay, so this is surgery. This is radiation therapy. Now, radiation therapy has changed quite a bit over the last 15 years. It's gotten much, much better. They can give precise radiation therapy right to the prostate area. Let's see, I want to go back. Here we go. Coming from the radiation head here to the prostate. And if we can give radiation therapy precisely to the prostate without a lot of spread to surrounding tissues, then they can have less, the patients will have less in terms of side effects and still get very, very good cancer control, which is obviously the most important factor. So in those patients that either can't tolerate surgery or don't want to undergo the risk of the prostate surgery, or for whatever reason, the radiation therapy has a very good rate of cancer control and has minimal side effects these days. Now, you can get erectile dysfunction, sexual dysfunction after radiation therapy as well. Keep in mind those nerves, arteries, and veins, they are right there, and they do not like radiation treatment. The nerves get stunned, the vessels get stiff, they don't relax and expand and contract like they used to. And so you still can get problems with erectile function after radiation therapy. Now, there's different ways of giving radiation therapy. This is the radiation seed implant. You can see here what this looks like on an X-ray. You have all these very tiny seeds implanted. These seeds are impregnated with radiation and they emit radiation over a very small area. And so you get radiation to the prostate, but not much to the outside surrounding tissues. And so this has been used probably 12 to 15 years for treating prostate cancer, treats the cancer well, but does have some side effects. And more, we're going towards external beam radiation therapy. CyberKnife is another way of giving precise external beam radiation therapy called CyberKnife. Loma Linda has a proton beam radiation therapy. Again, this is radiation therapy, but with a proton beam, which may have less side effects, but still good treatment. Okay, so this can really control prostate cancer well. The next option for treatment would be hormone treatments. And like we talked about on the previous slide, hormones, especially testosterone and androgen, as you can see here, feeds the prostate cancer. And so if we give hormone therapy like this medication Lupron, it causes the testosterone to go down to almost zero. Okay, and the Lupron, what it does, I'll just see if I can, let's go back to here. And you can see the Lupron works here. It blocks this message pathway so that the testicles stop producing testosterone and your level goes way down. And it's like cutting the food supply off from a cancer. Casodex is used oftentimes as well. This is a little bit different in that it's a testosterone receptor blocker. So what it does is you may still have testosterone, but it won't have any effect because the receptors are being blocked. Zytiga is another androgen blocker that stops any testosterone from being produced anywhere because some androgens, testosterone is produced in the adrenal gland, not very much, but some. And then below that is Standi, Erlita, and Nubeqa. These are newer medications that can be added to Lupron. We're always coming up with newer therapies for prostate cancer. And a lot of these therapies, like these, are modifiers of hormone treatments. Now, when you do get hormone treatment for prostate cancer, you get that decreased libido, okay? You do get erectile dysfunction in terms of the decreased libido, and you can get hot flashes from the hormonal changes. These hot flashes are very similar to a woman going through menopause, where you all of a sudden feel flushed for just a very short period of time and then goes away. Fatigue and sometimes a little bit of weight gain can happen with hormone therapy for prostate cancer, but it works very well at pushing the cancer down and dropping your PSA score significantly. Now, in terms of treatment for prostate cancer, we've talked about active surveillance or, following it, surgery, radiation, hormone treatments. There are other treatments that we won't talk about today just because they're a little more experimental, including HIFU, which is high frequency ultrasound treatments, which has been done in Europe for many years, but not really FDA approved yet here. Cryotherapy, also gone through lots of iterations over the years, is actually being done more and more now with technological advances. So there's lots of different treatments out there. Some people are in some institutions doing partial gland treatment. In other words, they're just using HIFU or cryo for half of the prostate or just those areas with cancer. That's really, again, in trial stages to see if it really does control the cancer well enough. Okay, so now we're going to talk about those patients that have undergone treatment for prostate cancer and need help getting their erections back going again. We talked about oral medications briefly. There are vacuum pump devices, injection therapy, and ultimately penile implants. Again, in terms of the oral medications like Viagra, here's where it works. Keep in mind with these medications, you do not just get an erection. You need stimulation. You need this process to start, and then it speeds this whole reaction. So it gives a firmer, more long-lasting erection. But if you take a Viagra or any PDE5 inhibitor without any sexual stimulation, nothing's going to happen. But they work very well. Cialis, Levitra are other examples. This is an example of a vacuum pump device. This is something that you put over the penis. You either have a battery operated or manual pump. It draws the blood into the penis, and then you slip one of these rings in at the base to keep the blood there and maintain the erection. These work very well. They're just seen as sometimes obviously a little bit cumbersome. Injection therapy works very well as well. As you can see, you have a syringe with medication that you inject with a very, very small needle into the side of the penis. Now, these are these sinusoids that we saw earlier where these have to dilate to draw the blood in to give the erection. So if you bathe these in this medication, they will dilate and you will get an erection. So this is one of those things that if you do a penile injection, you will get an erection. It bypasses the nerves, it bypasses the veins, and you will get an erection after the injection on almost everybody. In this, you have to make sure to do the injection laterally. You don't want to do it here at the top because of these veins and arteries, or here at the bottom because this is where your urine goes through the urethra. Okay. Finally, if none of these are working, we can be a little bit more aggressive and do what's called a penile implant. These are surgical implants. This is an operation under anesthesia where we actually implant this device to give erection. It's what we call a three-piece device. And so what you've got are these cylinders within the penis. You've got a pump in the scrotum and a reservoir here in the abdomen. And what you can do then is if you pump, the fluid comes out of the reservoir and then into the cylinder to give erection. What isn't shown here, but on the pump, there's a release valve that then releases it and you go back to the flaccid state. This works very well. Satisfaction rates for these are very high. It's obviously more involved. There is a risk of having these foreign bodies essentially implanted, a risk of infection, and you can get mechanical failure and need revisions and this kind of thing. But the majority of time, these work very, very well. It's obviously just a little bit more involved. Okay. Well, that's been a lot, but just to review, we talked a little bit about the anatomy, and hopefully you've been able to learn what it is that allows sexual function to occur in men normally. And then if you understand that, you can understand a little better how these different treatments for prostate cancer can affect sexual function, including surgery. We talked about radiation treatments and different forms of radiation. We talked about hormone therapy. And then we talked about these treatments that we can do to get people going again after prostate cancer therapy. And so in the end, even if you have prostate cancer and you undergo treatment for that to control the cancer, you can maintain sexual function. It's just how far do you want to go with that? Obviously, the oral medications are easy. The vacuum pump devices are a little more cumbersome, but work. Then there's injection therapy. We can get you there one way or the other. It just depends on the patient's needs and wants. And I will say as a caveat that oftentimes I have patients after prostate cancer therapy, and I ask them about their sexual function, and they say, well, yeah, it's not really working, but we really weren't that sexually active before anyway. And honestly, it's okay. And that really is fine. And that happens a lot. And if it's not something that's important, then that's fine. And we don't need to go through these interventions. But if it is important in someone's life, we can help, we can get going again. And so I say again, sex after prostate cancer, yes, you can. And that is my talk. I think we ended on time. Let's see.
Thank you so much, Dr. Pearson. You ended right on time, and that was a wonderful and very thorough presentation. So thank you very much.
I'm going to go ahead and hit the stop share then.
Yep, perfect. All right, so it looks like we already have 2 questions for you. If anyone would like to answer or enter any questions into the Q&A feature, we'll be answering questions at this time. Okay, so the first question we have is, please compare penile implants. So they mentioned the Coloplast Titan ORT versus the AMS 700. And they wanted to know if can implanting a penile implant cause a side effect of problems with pee flow through the urethra?
Yeah, great question. That's a very educated question. So we talked about the 3-piece penile implants. There are different manufacturers for these implants. One is Coloplast, and they make the Titan, and then AMS, or American Medical Systems, makes the 700 CXR or the LGX. They're both very, very good implants. Really, what it comes down to is, for us anyway, it's surgeon's preference. And if you have a surgeon that is very familiar with the Coloplast, then go with the Coloplast. You don't want to have someone who's very familiar with the workings of the Coloplast, then try to use an AMS product if that there may not be as familiar with. For the patient, you won't know the difference. They're both excellent. They both have excellent results and very little in the way of infection rates or mechanical failure. They both have it's an antibiotic coating to prevent infection, and so they're both very good. In terms of the second part of the question, can penile implant surgery or the having of a penile implant interfere with urinary function? It really shouldn't. Okay, so it's a different system. It really does not involve the urethra or the bladder at all. And so your urinary function should be unaffected essentially by these penile implants that are used for erectile function, sexual function. But great question, thank you.
Wonderful, thank you. Our next question is shockwave therapy effective?
So, yeah, shockwave therapy has come up fairly recently. So shockwave therapy typically is something that we use for kidney stones. It's from the outside of the body. You have a shockwave generator that goes through your skin and soft tissue and pulverizes stones. What research has found is that if you use a very low power and just a handheld shockwave device to the penile area, that can help with things from Peyronie's disease, but also erectile function. It hasn't really been shown to be all that effective. It tends to be very expensive, and the results just in the scientific community, there's not a lot of work out there. There isn't a lot of scientific evidence out there. I think it's safe. It's been approved because this is a device that's used for something else, so they don't need to go through the whole approval process in the same way. So I don't think it harms people, but I'm skeptical. Let's just say that.
Great, thank you. Okay, our next question is, what do you think of IMRT and hormone combination treatment?
Yeah, so IMRT is intense modulated radiation therapy. So that is one of the newer ways that we're doing radiation therapy, similar to what I had talked about in the talk. It's been shown by studies that radiation therapy works better if you combine it with hormone therapy. And so what's oftentimes done is if you give hormone therapy for a period of about 2 months and then give the radiation therapy, rather than just giving the radiation therapy up front, the radiation therapy works better in terms of cancer control. Now, you also have the side effects of hormones, like I had talked about in the talk. So there's a trade-off there. And typically what your radiation oncologist is going to recommend is that if you have a more dangerous disease, they'll add the hormones to the radiation. If you have a really low risk disease, oftentimes then the radiation alone is perfectly fine, will take care of everything, and you don't need to do the hormones. But if you've got a unfavorable intermediate risk prostate cancer or a high risk cancer, they'll combine the two and it works real well.
Okay, thank you. Okay, the next question is, how do you think supportive counseling and talk therapy can help men overcome stressors around not being able to perform sexually the same as before?
Oh, it's essential. It's essential. Remember my slide, which I thought was kind of cute with all the different things, the stress, anxiety, all of this stuff. And honestly, like I had said, if everything is working perfectly great, but you're totally stressed out, it's not going to work. And so you need that kind of support or counseling in order to get over that, in order just to start the process. So I think it's essential.
Thank you, Dr. Pearson. I think this is a good time also to mention that here at Cancer Support Community Los Angeles, we have 2 support groups dedicated specifically to prostate cancer, where you are more than welcome to reach out to us if you're interested. We have a prostate cancer group. We also have a prostate cancer group for gay men, which we run with the LA LGBT Center. We also offer individual counseling. So, we're happy to provide support, and we know how effective talking can be and helpful in reducing stress. So please, if you're interested, go to www.cancersupportla.org and reach out. We're happy to get you connected. For our next question, can one of the side effects of taking Lupron be body aches or body pain, such as leg pain?
Okay, good question. Lupron, remember, is a form of hormone therapy. Excuse me. It is given every once a month every 3 months or every 6 months, and it's given as a injection, a depot injection that's typically given in the gluteus, so in your butt there. Um, so you can have some local effects from the injection site, usually very, very mild. You can have systemic effects, like I had said, in terms of tiredness, a little bit of weight gain, and this kind of thing. If you're having symptoms like leg pain, that's unusual in terms of being from hormone therapy. And so if you are having body pains or leg pains, you might look into some other potential causes for that, because I'm not sure that that might be due to the Lupron.
Okay, next question, also about Lupron. When taking Lupron and treating an aggressive cancer with Gleason scores of 6 and 8, how long should the Lupron be given?
It's a great question. Traditionally, once you're on hormone treatment for prostate cancer, you're on lifelong. You just get it and get it and get it and get it. More recently, what we have done is undergo what's called intermittent therapy. Okay, so this is where you have Lupron treatment for a period of time. If the PSA comes down appropriately to about 0 or so, or very low, in other words, that it's doing its job, it's treating the cancer, you can then stop and you hold and you enter what's called the observational phase of intermittent therapy, and you watch that PSA over time. And then if the PSA starts to rise again, back on the hormones, take it for 6 months or a year, bop that back down, follow it again. This is that intermediate therapy. So it really depends. It's an individual decision between the patient and their physician in terms of how long to undergo Lupron. I will say, back to the previous question, in terms of the combination of Lupron with radiation, the IMRT question, that typically is only a short course. So 4 months, 6 months, something like that, and then you stop. That is not a lifelong thing.
Okay, thank you. Okay, looks like we have 2 more here. How do you rule out prostatitis for high rising of PSA? I don't know if I said that properly.
Yeah. Prostatitis. And so what this it's a little bit of a long answer, but I'll try to make it as quick as possible. The PSA is prostate-specific antigen. It's a protein made by the prostate that we find in the bloodstream. If someone has an infection of the prostate or inflammation of the prostate, like prostatitis, that can bump your PSA up. Obviously, we're concerned with the PSA because it's our screening tool for prostate cancer, because cancer also makes the PSA go up. So if you treat the prostatitis, antibiotics, anti-inflammatories, fluids, that kind of thing, and then recheck the PSA, if it's come down, it was probably the prostatitis and not cancer that caused that rise in the PSA. So you can do that kind of thing. Ultimately, if we want to know whether there's cancer or not, you'd need a biopsy. But hopefully we can do some things to rule out other causes for a high PSA, like prostatitis.
Okay, so we have a couple comments here, people just sharing. One person said, even though a man can no longer have an erection nor an ejaculation, a man can still have an orgasm with proper stimulation. So sex is not over after treatment.
Agreed.
Yeah, thank you for sharing that. We also have another member, I'm not sure if this is a question. The optimal PSA rate following treatment is different for surgery versus radiation. Less than 0.01 following surgery and less than nadir +2 for radiation. So the PSA is different for surgery versus radiation.
Yeah, so that's true. Very true. If you undergo radiation therapy, keep in mind the prostate is still there. And so your PSA may not go to 0. It may go down to 0.2, 0.4, 1.2, something like this. If you have a prostate surgery, your prostate's gone, your PSA really should be 0 or really darn close to 0, less than 0.01, as the questioner says. So yes, you have to monitor differently if you've been treated with surgery versus radiation therapy.
Great. We have some very educated viewers here today.
Yeah,
Okay.
that's great.
Yeah. Does Lupron still cause man boobs?
Yeah, I was wondering if you were going to read that one or not.
Why not? Let's use the jargon that our community might know, right?
Typically, we call gynecomastia, but man boobs is the thing. So yes, Lupron can cause gynecomastia, which is either an enlargement of the male breasts, which can be annoying. Typically, it's not that bad. Another thing that men can experience after Lupron in this area is nipple tenderness and just a shirt rubbing, and it really can be annoying. One of the things that can help with this is if you give a very low dose radiation to the breast tissue, ideally before you start Lupron or even afterwards, that can prevent the gynecomastia or man boobs, and the nipple tenderness. So that's something. Yes, that does happen. There are things we can do to help.
So gynecomastia, is that the word?
Mastia, like gynecomastia.
Okay. See if I can remember that.
We'll quiz you next week.
Yes, thank you. Okay, we have a couple more questions we have time for. Should PSA tests be taken after 75 years of age?
So the American Urological Association guidelines now call for PSA testing up between age 50 and 70. And after 70, you no longer need screening for prostate cancer by guidelines. Now, that being said, this is an individual discussion between patient and doctor, and it's up to you. Certainly, that's for the general population. If you're someone that has had a PSA that has been elevated, or you've had problems with prostate, you probably ought to keep getting it checked. But if your prostate's been fine, PSA's always been normal, no strong family history, you could probably skip it.
Okay, great. Just someone else sharing that PSA, which is prostate-specific antigen, is also known as prostate-specific anxiety.
Yeah, I think what he's getting at there is that patients that have had prostate cancer treatment, especially something like radiation, and they follow the PSA, that's our monitor. Is it coming back? Is it gone? Are we doing okay, essentially? And the thing that we follow is this blood test. That's all we have. And it does breed a lot of anxiety. Like, what's my PSA going to do? Is it going to go up? Am I okay? And so, yeah, it can be very anxiety provoking, and I feel for them.
Absolutely. And I think we hear that a lot in our community too, that anxiety comes after treatment, and, those worried about recurrence, or,
or even before, should I get a biopsy? Oh, it's high, but it's not that high. Should I? What's my next? We'll check it again. What's that going to be? It causes anxiety for sure. Absolutely.
So another good reason to join a support group and people who understand your experience. Yeah. Okay, it looks like that's all the questions that we have for today. Thank you so much, Dr. Pearson. This has been a wonderful discussion. And just as a reminder to everyone, this is being recorded and will be up on our website video library within a month or so. You can also rewatch this at any time on our Facebook page at Cancer Support Community Los Angeles. And we are so grateful for you being here today. Thank you so much, Dr. Pearson.
Thank you. Thank you very much. Take care.